Kia ora everyone, and welcome to this Goodfellow webinar on shoulder pain, not always what it seems. My name is Dr. Grace Lee, and tonight I'm joined with Dr. Craig Ball, who is a shoulder and elbow specialist and orthopedic surgeon from Auckland Bone and Surgery. Over to you.
Thank you very much, and thank you to the Goodfellow Unit for the invitation to present at this webinar. And yes, please, I'll just reiterate what Grace has said. This is meant to be very much an interactive session, so as many questions as possible. I've done a framework of a talk, but this can really form the basis for a lot of other questions that I'm more than happy to answer as we go along. Obviously, as a shoulder surgeon, the shoulder is what I live for. But I appreciate that I'm in the luxurious position of only dealing with shoulder problems. So part of the reason I guess I wanted to do a talk like this was just to help bridge the gap and improve understanding of shoulder conditions, and in particular shoulder pain. Shoulder pain is a very common problem. It's the third most common musculoskeletal complaint. The big problem, though, is that the diagnosis and management of shoulder conditions can often be very challenging, and I'm sure for those of you who are involved in the care of patients with shoulder problems, you very much would understand that. Why is that? Well, often they present late, so the presentation's often delayed. They can have more than one problem at once. Many conditions can present with similar symptoms, so that's, I guess, the crux of this talk is don't always think of one problem when a patient comes with shoulder pain. There's a number of different pathologies that can coexist. I'll just start with a little bit of the basics, a little bit of anatomy, because I think with regard to pathology in the shoulder and shoulder pain, it is very important to understand the anatomy, because that helps us understand where pain might be coming from. The joint itself, by design, has to be inherently unstable. It's the most mobile joint in the body, so therefore it has to have a degree of instability. And the stability is therefore determined by the soft tissues, not the bone. And there's two parts of that. You've got the static restraints, which are the ligaments, and really the ligaments are thickenings of the capsule itself, and they become tight at the end range of motion. They're the static restraints. Then you've got the dynamic restraints, which is the rotator cuff and the other muscles around the shoulder, which I'll talk about in a moment. But as you can imagine, because of what I've alluded to with ligaments and capsule, if that capsule and those ligaments become thickened and contracted, that can be a cause for motion loss, just like if they become very loose, it can be a cause for instability. This is really the crux of the shoulder, though, the rotator cuff. If you look at these cadaveric dissections, I'm sure you can appreciate that it's quite a dramatic structure, really, because when you think of the rotator cuff, we all probably understand that there's four separate muscles around the shoulder that make up the rotator cuff, but in reality, they really attach as one separate tendinous sleeve around the humeral head, separated at the front by the long head of bicep tendon between the subscapularis and the rest of the posterior rotator cuff. It's got a very complex function. In fact, we probably don't fully understand all that the rotator cuff does. It is important in stability, as I've said, but it also functions primarily in coordinating shoulder motion, keeping the humeral head centered while the other bigger muscles move the shoulder around. Rotator cuff runs through this specialized space, the subacromial space. Again, there's a lot that we don't understand about the subacromial space. We don't really know what the function of the coracoacromial arch is. We think maybe it's a protective element, but the big problem is because of the demands of life now, our sport, our work, we do probably a lot more than the shoulder's built for. And so that's why we see a lot of pathology in the subacromial space, and particularly with the cushion that separates the rotator cuff from that coracoacromial arch called the subacromial subdeltoid bursa, because often that can be compressed, impinged as the tendons move underneath. And then everything, of course, is surrounded by the big overlying muscles, and that makes it even more complex because you don't even see or really feel the rotator cuff, so it's hard to get a good idea of function of that when you've got these other bigger muscles around the shoulder. And I think it's important not to forget too that when we think of shoulder movement, it's not just the glenohumeral joint. 2/3 of shoulder movement comes from the ball and socket, but 1/3 is the shoulder blade moving on the chest wall. So a patient who can elevate their arm maybe up to shoulder height, that movement may just be all scapulothoracic. So there is a complex interplay around the whole shoulder girdle, and it's important when we think about the shoulder not to just focus on the joint itself, but the whole girdle around that region. So for me, I think about the shoulder somewhat in layers, understanding that pathology can occur in more than one of those layers at the same time. And this is where the history and examination are going to be very important. And yeah, if we think just of those 4 layers that I've talked about now, the joint with its capsular and ligament, the rotator cuff, the subacromial space, each of those can have separate pathology which may be relevant in the patient that you're seeing with shoulder pain. So when I think of assessment of shoulder pain, obviously the primary aim in primary care, be it general practitioner, physios, whoever, is to try and establish an accurate and definitive diagnosis. And that's where, obviously, as I've said, it can be difficult with the shoulder. But I think it's important not to forget the basics. And for me, the history and examination is the most important thing in helping me to make a diagnosis in these patients. It's not the use of imaging studies. They're just really adjuncts to help confirm what I'm thinking. And it is important, again, to remember that different shoulder conditions can present very similarly. So it's always important to have a broad differential diagnosis to begin with. If you don't think of a particular problem, then you're not going to diagnose that particular problem. And also it's important to understand with the shoulder too that where people feel pain often does not correlate as to where that pain is coming from. Even though the patients will focus on my pain is here or here, it doesn't actually help us understand where it's coming from. So it is important to take a good history, and most of the time you'll be seeing a patient because of shoulder pain. Obviously we have all our pain questions, but there are associated symptoms that are important with the shoulder too, particularly feelings of stiffness, weakness around the shoulder, or instability as being the main 3. And again, remember, yes, common things do occur commonly, but in the shoulder, the presentation and pain patterns, unfortunately, are not very specific. So we do have to have a broad mind, keep a broad open mind when you're first seeing a patient, not to just assume everyone's going to have the same sort of problem. The other issue, as I'm sure we're aware too, is that clinical examination around the shoulder isn't always that helpful either. There's many examination tests that we can do, and there's whole textbooks showing different examinations around the shoulder, but none of them really are valid and reliable for any one specific pathology. So again, it's putting the whole thing together, the history, the examination, using confirmation from imaging. And for me, and I think in the primary care setting, probably the most important is a good examination of range of motion, and I'll explain why in a moment, and also understanding what provocative tests might actually cause that patient pain. So yeah, don't forget the good history and examination. I know it's difficult in the primary care setting because of time pressures, etc., but that's actually going to make the diagnosis in the majority of cases. Look for the associations, the examination in particular. If you don't have the time, and you don't really need to do a whole heap of provocative tests, but a good assessment of range of motion will help in the vast majority of these patients. And also consider age too, which I think is very important, because some of these pathologies you only see in younger patients, some you'll only see in older patients. So that can help you in targeting what further investigations or what treatment you might be initiating as well. Such that an under 40-year-old consider things like subtle instability, labral tears, bicep pathology. With the over 40-year-old, obviously it's going to be your more common problems, the rotator cuff, frozen shoulders, and glenohumeral arthritis. A good example, and this is a very common problem that I might see, 52-year-old female, 3 months history of shoulder pain. Not exactly sure when it started, maybe lifting a weight in a gym, thought she'd overstrained it. Now the pain's getting worse, it's no longer being helped by anti-inflammatory, starting to wake her at night. So when I'm seeing a patient like that, that's very important information already, because although many diagnoses are possible, I'm not thinking in her that she's going to have a traumatic rotator cuff tear, because the mechanism of injury and history is not consistent with that. and the progressive worsening would be more in keeping with either worsening subacromial pathology such as bursitis and persistent impingement, or perhaps a frozen shoulder. And this is where then a careful examination, particularly of range of motion, will often help you identify a cause even before you've thought about doing any imaging. Imaging obviously is very important in the shoulder though, because of the difficulties with that examination and history part of it. I think probably the main crux I want to get across is, regardless of whether or not we think plain X-rays are useful in the majority of patients, they should always be performed. Nowadays, it seems like we always think ultrasound, but I think if we can come away from this always thinking, yes, let's get a plain X-ray as well. It's not that there's a lot of validated clinical decision rules, but plain X-rays for me are very important to rule out other causes of shoulder pain, and they do help us understand a lot of subtleties that might be going on in the patient's shoulder as well. Again, we have to take imaging studies in the context of that history and examination, because often in the older patients you will see pathology which might not bear any resemblance or relevance to the treatment that they require. I mean, you've all seen reports probably of sclerosis, spurring of the undersurface of the acromial, greater tuberosity cysts, where the radiologist might suggest this would be consistent with impingement and rotator cuff pathology. But these can also be entirely normal and an age-related finding. So, yeah, if they're relevant because of what you found in the history and examination, great, but don't put a lot of weight on them. And similarly, acromioclavicular joint arthritis, over the age of 50, it's almost a uniform phenomenon and finding. Imaging, ultrasound, it's always the orthopedic surgeon's bugbear, I guess, because we know that ultrasound is the only investigation, at least at this point in time, that's easily accessible in the primary care setting. And it is valid when used for the appropriate reasons. But if you look at the literature, it's really only been demonstrated to be a valid tool for excluding a full thickness rotator cuff tear, not much else. So it can't assess intra-articular structures, it can't give you any good assessment of muscle quality, and particularly if you've got a very painful stiff shoulder where that patient has lost range of motion, even in the most experienced radiologist's hands, it's going to be very unreliable. So yeah, think about the patient, think about what information you're wanting and indeed expecting to find from the ultrasound before ordering it, and then yeah, still interpret that in the context of what your history and examination has found. And I guess one of the issues we have is that rarely is an ultrasound report say everything's completely normal. So almost always you'll get a report suggesting there's bursal thickening, bursal fluid, and yeah, obviously if you've got a patient with shoulder pain, many people just hone in on that thinking, oh, this patient's got bursitis. But yeah, we know that if you take 100 random people off the street and do ultrasounds, over 50% of them will have exactly the same findings. So anything you see that's positive on imaging, don't just assume that that's the cause of the patient's symptoms. Similarly, partial thickness rotator cuff tears too, very uncommon under the age of 40, but with each decade after that, it's almost an expected finding for me, and again, may not be the source of the patient's symptoms.
Just before we move on
yes.
to this, to the MRI, taking a little step back with regards to thinking about the examination stage,
yes.
Someone's just posed the question of how can we diagnose rotator cuff and frozen shoulder by examination?
Okay.
Any key pointers there?
Yes, so I will go into that a little bit more detail, but the key thing really, and I guess for me as a specialist, what I've noticed is that over 90% of patients I see with frozen shoulder have not had the diagnosis made before I see them. So that means that most people don't think of the diagnosis, and I think that's because most people see an ultrasound which suggests bursitis and impingement, so they immediately think this is a rotator cuff problem. So the one hallmark of frozen shoulder is the painful loss of both active and passive range of motion. So that's why I've harped on a little bit about the assessment of range of motion. Yes, someone with a rotator cuff problem, be it impingement, bursitis, or a rotator cuff tear, they'll have shoulder pain, and it may be painful for them to put their arm through a range of motion, But if you take the patient's arm and you move it itself passively, then rarely is there any significant limitation of range of motion. That's very different from a frozen shoulder, where the patient will move at a certain point, and then if you try and take it any further, it will not go, and it will be very painful. And that's because the pathology is in the capsule. So if you try and then stretch that capsule even further, it is very painful. So yeah, the difficulty is when frozen shoulder is subtle. They've lost maybe 5 or 10 degrees, and a quick cursory examination and you think, yep, their movement's pretty good. But if you really assess that difference between active and passive motion, you can always identify it.
Good tip, thank you.
Good. So we obviously have the luxury of being able to arrange for MRIs to be done, and I think they are being used increasingly. I know ACC are doing trials with primary care providers to see if there's an appropriate space for indications for organising them, which I think there is. I mean, I use both a combination of plain MRI and MR arthrogram. So a plain MRI for me is when I know there's pathology there, and it's more about getting more information about that pathology, such as a large rotator cuff tear, when I need to know truly how big it is, how much the tendon's retracted, the extent of muscle belly changes, because that's going to be important in determining repairability and what I might do at the time of surgery. Whereas if I'm uncertain about the diagnosis, I'm thinking, is this a partial rotator cuff tear, is there some labral pathology, then I'll use contrast, because we know that an MR arthrogram is much more accurate and sensitive in differentiating between those more subtle pathologies. Again, I'll go through that in a little bit more detail. So take-home points from this is, don't base your treatment decisions from imaging studies alone when it comes to shoulder pain. And even MRI is still just a guide. I did a study a few years ago looking at MRI and correlating that with what I found at the time of surgery, and 30% of the time MRI will miss pathology in the shoulder that will have a significant impact on what I did at the time of surgery. So it is still a guide, and as I said, pathology may be normal for age, and that's where overuse of MRI can be a bit dangerous too, because if I MRI'd my shoulder, I'm sure there's going to be a lot of pathology there, but it doesn't matter because I don't have symptoms. It's not an issue for me. And as I said, many of shoulder has been misdiagnosed because of over-reliance on the radiology report. And we have the same issue at times with applications for ACC, because the radiology report holds a lot of weight. And so trying to get across to understand some of the subtleties there is what we're trying to achieve as well. Again, if we go back to that same case example, and this will allude back to that question as well, this is that same lady. The examination did notice that there was loss of both passive and active range of motion. So she had a stiff, painful shoulder. It's worsening, troubling her at night. She gets sent off for imaging studies. The plain X-rays are unremarkable, but the ultrasound, as it often does, reports evidence of bursitis, dynamic impingement on movement, but no evidence of a rotator cuff tear. So you've made the diagnosis with your history and examination. The imaging studies will really just to say, does this person have more significant pathology like a rotator cuff tear? No. Forget about the other thing it says. So until proven otherwise, this is likely to be a frozen shoulder because of the loss of both passive and active range of motion. And moreover, if you give that person a subacromial injection, it generally won't have any significant benefit because the pathology with the frozen shoulder is intra-articular, not subacromial. So we'll move on a little bit and talk about some of the more painful shoulder conditions. Probably in general practice in particular, the top two, rotator cuff problems and frozen shoulder, are the most common you'll face. But I'll mention a few of the other ones that I see as well, just because they will crop up. And there's some useful tips that I can provide in terms of sorting out some of the shoulder pain in those cases. So the rotator cuff, there's no question that it's the main problem area of the shoulder. It's the most common upper extremity disorder that we see, but it's rare before the age of 40. And I think that's a very key point to take home as well. So someone with shoulder pain, 25 years of age, almost never is that going to be a rotator cuff problem. Why do we see it with age? Well, we know that unfortunately our tendons do wear out everywhere as we get a bit older, as well as our shoulder being subject to a whole variety of adverse factors, micro injuries, macro injuries. So it's perhaps not surprisingly that as each decade progresses, the incidence of rotator cuff pathology and indeed full thickness rotator cuff tears does increase. Reports are variable, but probably my figure is 30% by age of 65 will have a full thickness tear. It's also important to understand that most of those patients will be completely unaware that they actually have a rotator cuff tear in their shoulder. They'll have completely normal movement, they won't have pain, their strength will be fine because it's a tear that's slowly progressed over a period of time, so there's no defunctioning really that happens. And so these are the patients where they might have a relatively innocuous injury, suddenly the shoulder becomes symptomatic. That is not a traumatic tear, that is a pre-existing tear that for some reason has been rendered symptomatic. Often we don't know why that is. So bear that in mind, is that, yeah, not all rotator cuff tears have just happened. Most of them, in fact, probably haven't. The other term that's bandied around a lot is this so-called subacromial impingement syndrome, whatever you like to call it. It's not, impingement is not a diagnosis. It's really just a term used to characterize or describe a pattern of presentation that the patient has. And there's a similar constellation of history findings, pain patterns, findings on clinical examination. Lots of different pathology can present with subacromial impingement, including some pathology inside the shoulder joint, which I'll allude to as well. So if you see impingement being described on an ultrasound, that's not a diagnosis. You need to look further and try and establish what is actually causing that patient's impingement. And for me, the only reason that I might organise an ultrasound scan is when I want to exclude a full thickness rotator cuff tear, because that would be the most important thing that might influence the management of that patient. So we look at some of the conditions now, bursitis, tendinitis, tendinosis, again, terms that are bandied about, but basically these are the patients who do present with that impingement. We've all seen them, the painful arc, painful provocative testing, pain, when they're using the arm away from the body under load, often they get a lot of night pain as well. The biggest differentiator, going back to that first question again, is a proper assessment of their range of motion. Usually these patients will have full, often active, but definitely passive range of motion. If they don't, then immediately you've got to think maybe this is actually a frozen shoulder and not a bursitis type of problem. And again, bursitis is really just a term. I think of it more as a mechanical, biomechanical dysfunction, really. So something happens, often it relates to the middle-aged person, their cuff starts to fail a little bit, it doesn't work quite so well, and so because of the altered rotator cuff mechanics, they start to impinge, they get shoulder pain, and then they develop this whole vicious cycle. And that's very important when it comes to treatment. So think of the inflammation in the bursa as pain that inhibits the rotator cuff. The rotator cuff then can't do what it's supposed to do, which is help stabilize the shoulder joint and keep the humeral head in the joint. So therefore further impingement occurs, further inflammation in the bursa. And so what we need to do is always two things. A subacromial injection in those patients, wonderful for pain relief, but is never the only treatment that's required. So for me, the most important part of the treatment is improving the rotator cuff mechanics. So improving the cuff, the scapular stabilizers, postural control, because that's what the problem is in that patient. As long as they don't have a rotator cuff tear, then it's all about rotator cuff mechanics. So for me, I use an injection to break the cycle and provide a window so the patient can get underway with the exercises. That's why often if you have these patients, you organize a subacromial injection, but they don't do anything else, 6 or 8 weeks later, they'll be back. The pain will recur because they're not doing anything really to try to treat the primary pathology. So never do one without two.
With regards to the injection, is this something we can do in our office?
Yes, if you're confident to do it, for sure. So, I mean, I prefer to give all my own injections. I was actually involved many years ago with the ACC guidelines for shoulder, and our recommendation was that for most people, an image-guided injection is probably the way to go. But I have no problem at all with primary care people doing injections if they're happy to do it. The reason I like to do it myself is because even if I refer someone for an image-guided injection, it doesn't necessarily guarantee that they're going to put it where I would want it. And that can be both subacromial or intra-articular. Plus, I'm very particular about what I use in my injections as well, the volume, the amount of Kennicort and things, and so I don't necessarily can't control that if I'm referring someone for an image-guided one. So I give my own injections. I have no problem if someone's happy to do it. But yeah, I mean, if you're not comfortable and confident enough, patients don't like you digging around trying to find the space, so refer them.
It's a bit of a challenge point, I think, for us, for ones that aren't under ACC.
Yes.
With cost, really, which is what it comes down to. So I think a lot of us would like to have the confidence to do it, but it doesn't necessarily equate to having the skill.
Yeah.
It's challenging.
Yeah. I mean, it's a skill that's easily learned, and I think there are facilities like the Goodfellow meetings and later on this year where having stations where you can just understand how to easily access the bursa in particular is fine. But yeah, I understand completely as a time factor involvement as well. So, but if they're not ACC, that's the main issue, because at least ACC now have come on board, and it's not just, yes, they allow one injection and then that's it. They do realise that sometimes a patient will need 2 or 3 injections as part of a treatment before they come right.
Okay, thank you.
So yeah, the good news about these patients is that almost always they're going to get better. They just need to know that it will take time though, unfortunately. So it's not they're going to be fine in 2 months. It might take them 6, 12, 18 months. So any shoulder pain, I tell patients, there's no quick fix. It takes a bit of time. Often they'll respond and then recur, and you may need to reinitiate the treatment. But if there's no structural problem, my main aim is to avoid an operation. I mean, there's lots of reports about acromioplasty for people with impingement and bursitis, but the reality is, it was interesting, there was a recent sham surgery study out of the UK where outcomes were no better for an arthroscopic acromioplasty compared to just a simple bursoscopy or even non-operative treatment. So we still don't know the role of surgery, and so for me, I rarely operate on the patient unless there's a structural reason to do so, like a rotator cuff tear.
So with conservative treatment, just walking back to some of the strengthening exercises that you've talked about,
yes,
do you have any handouts that you give to patients?
Yes, I do.
Particular exercises that you'd recommend?
Yeah, so I give all my patients who I'm doing non-operative treatment, I have a set of strengthening exercises which look at posture, they look at rotator cuff, and they look at scapular stabilizer strengthening exercises with therabands. So they're all low load repetition. I explain to them that there's things that they need to persist with for not just a few weeks, but usually a few months. And if they do that, then the results can be very successful. Many studies have validated the use of exercise as being very successful. Yes, physiotherapists, good physiotherapists who understand the shoulder and shoulder mechanics can be wonderful in these patients as well, particularly if they've had a very long history of abnormal mechanics around the shoulder. There's a lot more retraining that's required. I explain to the patient that it's a mechanical issue, so therefore surgery doesn't really have a role because we can't address a mechanical issue. If they still have issues after they've been through that whole program, they're the ones who may benefit from an operation.
And are there any particular websites that you may recommend general practitioners or other primary healthcare practitioners in terms of trying to help them, guide them with regards to some of the exercises?
Yes, there is. I mean, my website's about to be revamped completely, and the whole aim is to have all my handouts on there as well. But most of the shoulder surgeons around town will have handouts where they'll have shoulder strengthening exercises. A lot of the physiotherapy groups will have as well. And for me, it's just a single double-sided sheet of paper I give to the patients, provide them with a couple of therabands, and away they go. The other important thing with non-operative treatment is that these patients need review. So if I inject someone, I always see them back 6 or 8 weeks later, just to make sure that they're moving in the right direction, and we don't need to adjust anything either. So not sending them off for 6 months of physiotherapy and hoping for the best.
And in your clinical experience, what percentage of people would you find would have success with an injection?
The vast majority. So for me, I can't think of the last time that I've done a simple arthroscopic acromioplasty. I do it when I'm treating acromioclavicular joint pathology, but then the primary problem is the AC joint. So almost never, unless someone's got structural pathology in the rotator cuff, am I operating purely for bursitis or tendinosis and a cuff impingement problem. So most of these people will eventually get better.
Okay, great.
Good. Cuff tears, though, very different story. So once you've got that structural pathology, then it does change things dramatically, because we know if you look at the outcome for non-operative treatment in the presence of a rotator cuff tear, suddenly your success rates drop from 90% to less than 50%. By the same token, because of what I've already said in terms of the high incidence of asymptomatic tears in the general population, not all patients with a rotator cuff tear need treatment either. Many of them can be identified incidentally when we always used to do comparative ultrasounds of both shoulders. It's quite a high incidence actually of patients who might have a symptomatic shoulder on one side, but oh wow, look, they've got a tear on the other side that they didn't even know about. So definitely not all tears require surgery, but by the same token, they never heal without an operation either. So therefore, it always comes down to patient symptoms. Ultimately, that's what we're treating, the patient and their symptoms, not what a scan shows. So for me, that's the indication to do something, is if their symptoms start becoming significant and non-operative treatment is not working, they're good candidates. And again, the history and examination should guide you here. So even in a 60, 65-year-old, a normal rotator cuff tear, rotator cuff does not tear without some sort of significant injury event. So the person who's been gardening, lifting the washing basket, getting the shopping out of the car and gets a sore shoulder, they haven't torn their rotator cuff. They've developed impingement pain, and they may have a pre-existing rotator cuff tear. So take the keys from your history. Also, if someone does suddenly tear their rotator cuff, they're going to know about it right at that time. They'll have sudden onset of pain, functional limitations. They're not the patient who a week or two later their shoulder starts getting sore. So identify and think about those keys. Examination doesn't really help you otherwise. The history is very important here. Why do we get interested about the full thickness rotator cuff tears in particular? That's because of the natural history. So that's been well documented. The problem is we don't know why some patients develop symptoms and others don't. We don't know why some tears will progress and others don't. But in general, what I say to patients, particularly if their tear size is starting to get up to 1.5, 2 centimeters, is that in general, all tears will slowly get bigger in size. The tendon will retract, and the muscle, because it's not attached to anything, will undergo certain changes. It will atrophy, you'll get fatty degeneration. So there are longer term implications of non-operative management of some of these patients too, which we want to avoid. So that's what, as a surgeon, I'm always thinking about too. So for me, it comes down to the patient and their symptoms. If they have pain, functional issues that interfere with quality of life, they're not appropriate for or haven't responded to non-operative treatment, then they're the ones that I may indicate for surgery. But they need to appreciate it's a long recovery because of the long biology for healing. So just briefly, because it's not really that relevant, so I still think about non-operative treatment, but young patients in particular, large symptomatic tears of any age, big tears that may have been pre-existing that have been now rendered symptomatic if they're still repairable. They're the ones that we prefer to see earlier, because they're the ones that we want to have a discussion with about surgical management.
What about those individuals that are of an older cohort, so think about 75 plus years? Do you consider surgery on them?
I do. The literature is controversial, and I know there was a question asked exactly about that. So age is not a factor for me, because I mean, what I'll often say to patients is that some of the best patients I have following rotator cuff repair surgery are those in their 70s. for some reason they have less post-operative pain, they find the whole process a lot easier, their demands and expectations are less. Yes, they may not heal their rotator cuff tears as good as a 50-year-old, and we know that from the literature, but the results of surgery can be just as good. So now I do many rotator cuff repairs in people well into their 70s. I think 80, 81's the oldest I've done, but it's always for me about physiologic age. It's not the number. So an otherwise fit and healthy 75-year-old who's got a repairable full thickness tear and significant symptoms, absolutely, they're good candidates. Now, not all of my colleagues believe that, because if you look at the literature, it says be cautious in those over the age of 65. And I think that's a little bit overcalling it. We know that not all tears heal after a rotator cuff repair, but the patient can still do significantly well because of all the other things we do at the time of operation. So, yeah, I certainly would advocate repair in those older patients as well.
And for those older patients that aren't candidates for repair, what can we offer them in primary care?
Then it becomes a little difficult because their biggest problem tends to be pain, particularly night pain, and we know the most effective thing at trying to eliminate that night pain is a subacromial cortisone injection. So I do have a number of patients who either don't want operations or who aren't suitable that I do just treat with occasional injections. The problem is if you get a patient that doesn't respond to that, because then you do start running out of options. And if they can't manage with medications, the injections are no longer having effect, and then they're starting to have an impact on quality of life, we may need to look at surgical management for those, purely from a pain point of view, to manage their pain.
Okay, thank you.
I mentioned again partial rotator cuff tears. So for me, when I'm looking at a partial tear, I almost think if you're over the age of 40 and have a scan that shows a partial tear, it's probably part of the normal aging process, particularly if that tear is interstitial. So I don't get too excited about it. I treat them very much as I treat that impingement patient with non-operative treatment. So really a significant partial tear for me is only if it's quite extensive and extends at least 50% or more through the tendon thickness, because those tears are more likely to progress to become full thickness tears. So we may occasionally think about surgery on those patients, but I will spend a lot more time managing partial tears non-operatively than I will a full thickness tear. And the same thing with calcification too. I think it's important to understand that it's very common. Incidentally, it can occur in up to 15 to 20% of people. So if you see someone who presents with shoulder pain, has impingement, the scan or an X-ray shows some small deposits of calcification, they're probably completely irrelevant in terms of that patient's presentation. They're not the cause of their impingement. They just happen to have calcification in their rotator cuff. So it doesn't affect management. We treat them as if it's a rotator cuff impingement problem. And there's only two situations with calcification where that's different. One is you'll very occasionally see someone with a florid acute calcific tendinitis where they've had a big deposit and the body is now actively reabsorbing it. They get this intense chemical inflammatory bursitis. It's a very dramatic presentation. It almost looks like a septic arthritis. They're so sore, they can't move anything, they're miserable. But they're actually treating themselves. So if you support them, give them an injection, reassure them, within 2 to 3 weeks, they'll get better and better and better. The more difficult ones for us are those ones who've got very big deposits, because if it's very large, then because of the fact that it means the tendon's less compressible, then yes, their impingement is going to be more problematic and harder to treat because they do have some sort of structural issue within the tendon. But thankfully, we've got other options like barbotage, get the radiologist to try and break down and aspirate some of the calcification. It's really just trying to find a stimulus for that person to resolve their calcification so we don't have to go in there and chop it out.
Great.
So full thickness tear, early referral. Partial thickness tears, don't be afraid to treat non-operatively. So usually they don't require surgical treatment. The same as for calcification too.
Can we just do a couple of questions before
Absolutely.
we move into our case. Conservative therapy is definitely where we sit in primary care.
Yes.
So I've got a couple of questions. One, someone's just posed a question with regards to what about protein-rich precipitate rather than steroid for pain management? Any
Yes.
thoughts there?
Yeah, I think PRP and some of those modalities are still, even though they've been available for a long time, they're still somewhat in their infancy in terms of our understanding and in terms of our scientific proof. There's no question that I believe their efficacy is as a pain relieving agent. What we haven't been able to prove yet is that they do anything more than that. So in terms of dealing with, or like healing partial thickness tears or providing some better healing response, I don't think that happens. But yes, I do believe that there are some patients with PRP for bursitis who will get good pain relief from them. The problem is at the moment that none of those treatment methods are funded by either ACC or private insurers because we lack the scientific evidence yet to prove beyond anything else that they're better than anything else. So, and none of it's cheap. So the problem is at the moment the patient has to self-fund those treatments. But yeah, I think they will become increasingly used, and a number of us have PRP machines in our practice. But it's just getting that good evidence and that understanding about exactly what the appropriate preparation is very difficult yet.
Okay. And how many times can we inject the same shoulder?
There's lots of old wives' tales out there, shall we say, and the number 3 seems to be bandied around a lot. For me, I think the whole evolution of cortisone injection has changed. Yes, it's still risk and benefit. I think the days of thinking there has to be a treatment paths of 2 or 3 injections for one pathology is not there anymore. So I inject a patient, reassess. I never re-inject at that stage unless they get a recurrence, and then we reinitiate the whole exercise regime as well. So for me, it's all about how frequently they're given and what it is that you're treating. So as long as it's not a structural problem like a tear, then I have no problem if it's spaced several months apart to carry on almost indefinitely. And I have many older patients who I see every 3 to 6 months, give them an injection, they're great for another 3 to 6 months, and I've been doing that for years. So as long as they continue to get good benefit from it, I don't see there's a big downside.
Okay.
Now, again, it's very hard to prove, and there have been analyses done looking at what are the downsides. We don't know is the simple answer. In the joint, yes, I think there can be an issue with cartilage, so I don't like to give any more than 2 injections for a frozen shoulder, for example, into the joint. It probably does weaken tendon tissue to an extent, so I don't like intratendinous injections. So for tennis elbow, I never give more than 2 to 3 because I think then you're potentially asking for trouble. But because the shoulder we're injecting into big spaces, as long as there's no structural pathology that it may influence, then I think as long as you're spacing them well apart, and more importantly, the patient's getting good response to it, then there's no set number.
Great, thank you.
So, 63-year-old builder, 2-month history of shoulder pain. Again, look at the history. Started to get sore lifting jibboard overhead. Starting to get sore at night. Painful impingement, little bit of weakness. So a builder at 63, you're probably thinking he's going to have a lot of wear and tear in the shoulder, may even have a rotator cuff tear. Lifting jibboard overhead, probably not enough to cause an acute tear. So plain radiographs, probably appropriate for age, bit of AC joint arthritis, small subacromial tear, and his ultrasound shows a bit of tendinopathy everywhere, partial tearing of this and that, subluxation of the long head of bicep. Whenever you see multiple tendon involvement with tendinopathy, partial tears, almost always that's degenerative pathology, intrinsic, age-related. It's probably got nothing to do with the fact that he lifted the jibboard overhead, apart from the shoulder didn't like it and it started to get sore. So that person, I'm definitely not thinking immediately of operations. I'm thinking, can we get that shoulder settled down to what it was like before? Because that person needs to continue working. He's not going to want 6 to 12 months off work because you'll probably never get back to it. So again, these chronic situations where it's not acute structural pathology, non-operative treatment, we don't necessarily need to see those people early on. How's our time going?
Good.
Frozen shoulder. What I will say to you, very, very common. I probably see 2 or 3 people a week with frozen shoulder. And as I've already alluded to, most of those haven't had the diagnosis made before I see them. So if you've got a middle-aged woman in particular, a diabetic, often spontaneous onset, but there's no real significant trauma, the classics, the lady who reaches over the back seat of a car to grab a bag, feels a bit of a tweak in the shoulder, and then it gradually gets more sore over a couple of weeks, frozen shoulder until proven otherwise. The problem is, like many things around the shoulder, we don't really understand the pathophysiology of it, so there's a lot we don't understand about it. But going back right to the beginning, painful stiffness, that painful loss of both active and passive range of motion. So the history can be very similar to impingement and rotator cuff problems. The site of the pain is very similar, but if they've got particularly bad night pain, sudden movements are really sore, the extremes of movement, and they're stiff when you examine them, it's a frozen shoulder until proven otherwise. Now, a lot of these get referred to me, but these are ones where I do think there is a space for better management in the primary care, but the difficulty is making the diagnosis. If you make the diagnosis, all they really need is an intra-articular cortisone injection. That's all I ever do for them. I don't send them to physiotherapists, well-meaning as they are. Good studies have now shown that physiotherapy often makes these patients sore because they're trying to stretch out the inflamed tissue. Subacromial injections don't do anything because the pathology, as you see on that bottom right picture, is inside the joint. So as soon as I make the diagnosis, they get an intra-articular injection, and usually one injection is all they need. I see them back 2 months later. Most will say their pain's 80% better, so they're sleeping at night, they're more comfortable during the day. Their motion may not be much better, but as long as they don't have the pain, they can put up with stiffness, knowing that that's going to continue to slowly improve. And 90% of those patients I'll never see back again. The difficulty is the diagnosis. So whenever you see shoulder pain, think frozen shoulder is probably the key thing.
2 quick questions.
Yes.
Is there any issue with bone reabsorption in the intra-articular injection?
No, I think the simple answer is, although we've got concerns about chondrolysis, so issues with the cartilage, and we've all probably anecdotally seen a patient who have had an intra-articular cortisone injection or 2 and then relatively quickly get a florid arthritis. I think intra-articular injections, and I use plain xylocaine, and I use Kenacort from all my injections, I think are quite safe. But as I said, I never give more than 2 into the joint. But no, I've not necessarily seen big issues. You'll find anything in the literature about disasters and things, but for me, no, I don't see that there's a big issue in these patients, and it makes such a big difference for them.
And how common is it to see frozen shoulder in patients below the age of 40?
It does happen. I've seen an 18-year-old with a frozen shoulder, and I've seen an 80-year-old with a frozen shoulder. So you do occasionally see those that are creeping into the 30-year-old age group. But most patients will be in that 40 to 65-year-old age group. So that's the most typical thing. I mentioned instability, not because of the frank dislocations and the subluxations, but there is a group of younger patients who will have shoulder pain that's not subacromial or rotator cuff based. Now, these patients, they won't have perceived an instability event, but on their history, you will notice they've had some sort of relatively significant event happen to their shoulder. They've fallen on an outstretched arm, they've lost control doing a bench press, and the arm's been wrenched back into abduction external rotation. So there was a definite event. They've got deep-seated pain, they get mechanical symptoms, often they get secondary impingement. So these are the patients who don't get better with non-operative treatment, but they tend to be younger. So these tend to be the under 40-year-olds. Over 40, yes, we always think they might have torn their rotator cuff, but it's pretty obvious if someone's dislocated their shoulder or had a true subluxation event. So I guess the key take home for these, if you've got a younger patient under the age of 40, if they've had a significant mechanism of injury, the patient's not improving with the usual non-operative measures, they've had physiotherapy and exercises, they may have had a subacromial injection which hasn't really helped, think, okay, this person may have pathology in their actual glenohumeral joint, because a lot of them will. They'll have subtle labral tears, not to the point where the shoulder is unstable, but the term is painful unstable shoulder, where they get these classic catches in certain positions, soreness doing things. Often they can't do gym work or their normal work. It doesn't stop them in their tracks, but it just grumbles and grumbles and grumbles. The problem is that often these patients will have ultrasounds that show that the bursa is thickened, but injections don't work, or if they do, yeah, they might get 2 or 3 weeks of relief, but that's about it. So these are patients that, yeah, we're very happy to see, because at least we have the ability to think, okay, this person actually needs an MRI, because I'm now concerned about structural pathology within the joint. And this is the classic history. So they're often a little bit older, like the 30-year-olds, someone who's wrenched the shoulder backwards when lost control of a weight, can't do his normal gym routines, it's catching him, it's just grumbles, but it's not really bad like a bad rotator cuff or frozen shoulder. It doesn't often trouble them at night, but it's just not getting better. You may get a bit of impingement pain, but if you provoke the labrum, if you do classic labral tests, they'll be very sore. So yeah, don't be misled by the ultrasound. If you think, and again, you need to think also that, yeah, there's a different layer here, maybe inside the shoulder joint, then it's very appropriate to refer, thinking, yeah, this person might need MR because they may have pathology in their joint. I put arthritis there purely as a reminder yet again. X-ray, X-ray, X-ray. You won't miss it if you take an X-ray of your patient. And we've all been guilty of those painful stiff shoulders who get referred to us, and we think, oh, this is a frozen shoulder. They've had an ultrasound which shows no tear. You give them an intra-articular injection, helps for a couple of months, but then it comes back. Take an X-ray, oh, actually it's arthritis, not frozen shoulder. So yeah, if you ever refer someone for an ultrasound, just add to it, please also take a plain X-ray, and you'll never miss pathology like that. And then finally, for the sake of completement, don't forget about the acromioclavicular joint. Now, it's probably the easiest bit around the shoulder because it's the one site around the shoulder where patients can actually localize the problem, because they'll point to their AC joint and say that's where it's sore, and it's often swollen and tender there as well. We can also do diagnostic injections into the acromioclavicular joint to help with uncertainty, but you will see some pathology there. This whole thing of osteolysis versus arthrosis, yeah, I think it's safe to say anyone over the age of 50 is going to have an arthritic acromioclavicular joint, but thankfully almost never does it cause symptoms. So it's usually an incidental finding on an X-ray. It poorly correlates with symptoms, and I never touch the AC joint unless someone is very localizing and has pain there and pain with provocative tests. You will occasionally see the younger person though, who may have had a direct impact injury over the AC joint playing rugby, or they're a weightlifter, and they'll localize signs there as well. And that's basically what this other term is, osteolysis, which relates more to a repetitive microtrauma, fatigue, failure, resorption of the clavicle, but there's this big gray area in between. So, but most of the time, shoulder pain with AC joint problems are a more easier diagnosis. Management not always easy, and again, non-operative treatment is usually the way to go. I'll cut through that. I'll just put this one slide up because I mean, you'll all have patients who've been referred for surgeons who end up being declined by ACC, and it is an issue, and that's part of the reason why I do some work with ACC at the moment, is to try and bridge that gap a little bit. The important thing is it comes down to the injury itself, and so we've talked a lot about that history, and the history is very important because what's written on that history about the mechanism of injury is absolutely critical. We cannot establish a causal link unless the injury is clear-cut and likely to be of significant force and severity to cause structural damage. So that person lifting their washing up or shopping out of the boot of their car, that's going to be a hard sell, because it's not a mechanism of injury that is likely to have caused any true structural damage. And there's plenty of information about there. For example, this picture at the bottom where they've done scans on pain-free people. The pathology that you see is surprising. It's very common. So yeah, I know ATC is great because it helps patients get imaging, it helps them see specialists and things, but yeah, do think about when you're filling out those forms, etc., about helping the patient with their ultimate treatment as well, and understanding that history mechanism. So to finish up, and I know there's a few other questions that we can then move on to, we've talked about trying with shoulder pain to make a more accurate diagnosis. And for me, it comes down to the history and examination more than anything else. I use imaging really just to confirm my thoughts. Rarely am I surprised really about what imaging will show. Remember, site of the pain isn't necessarily where the pathology is, and different conditions present with similar findings as well. So it's a bit of private eye work required here. But if you at least understand the more common causes of shoulder pain, and hopefully over the last hour we've covered a few of those off, and have an index of suspicion, don't think that every ultrasound, because it shows bursitis, is an impingement problem. Think about those layers, consider the age of the patient and the different pathology in those layers. And probably the main thing is consider those other diagnoses all the time. Could this be a frozen shoulder instead? In a younger patient, am I thinking more that there's a structural pathology with the labrum or bicep tendon that I need an MRI to really sort out? So, and especially if that patient is not responding, as you would expect, to good non-operative treatment within a 2 to 3 month period, then they need to be reassessed, reconsidered to move on to that next phase. Always do your plain X-rays. Ultrasound really only useful over the age of 40 when you're wanting to determine whether or not there's a full thickness tear. And always consider the results of the imaging studies in the context of your clinical findings. I mean, I think as primary care people, be it general practitioners, physios, you've got the training to do a history and examination. Don't rely on the radiologist's report. They just report what they see. It may not be relevant at all to the patient you have in front of you. And if you feel it's appropriate, refer for an MRI. Lots of things that we prefer not to operate on. As I've said, impingement problems, low-grade partial tears, calcification, frozen shoulder in particular. Yeah, treatment. And yeah, it's not just thinking, oh, let's give them a subacromial injection and they'll be right. Think about the other things, modifying the patient's activities, an appropriate exercise program. Whatever causes pain in the shoulder interferes with the shoulder mechanics and causes some of that mechanical imbalance, weakening of the rotator cuff, poor posture. So whatever non-operative treatment you're doing always should be accompanied by an appropriate exercise program directed towards improving that mechanics. But yes, as a surgeon, we do like operating, and there are certainly things we would like to see. The true full thickness tears, the higher grade partial tears, the labral pathology cases, any instability, glenohumeral arthritis. And although, I mean, I think we're a lot better and patients are understanding now that seeing a surgeon doesn't mean automatically that sign here, you get an operation. Hopefully, at least it means that we can have a discussion with them to talk about what the options are. At least they can understand the role of surgery and make a more informed decision about how they want their shoulder pain to be treated.
Great.
Good, thank you.
We've gone through many of our questions as we've had this presentation today, which is fantastic. Just a few last questions.
Yes.
What is the role of hydrodilation with frozen shoulder treatment?
Controversial, shall we say. So I am not a big believer in hydrodilatation, but there are many centres around the world that are, and there are many cities, for example. So in Australia, Melbourne is the centre for hydrodilatation. We do have one of the expert radiologists in Auckland, Neil Stewart. He has developed a very defined framework for patients he will do hydrodilatation on. I've always been skeptic because when you look inside patients with frozen shoulder, it's not a uniform contraction. There are various areas which are more thickened and contracted. And so for me, if you're just trying to dilate and rupture the capsule, you're not necessarily going to be rupturing the more contracted areas, and so you will get a bit of collateral damage. Plus, they always give those patients a cortisone injection at the end of the procedure. So is it the hydrodilatation? Is it the cortisone injection? So my own personal experience, and I see a lot of frozen shoulder, is that they can manage fine. You always get 5 or 10% who are more difficult to manage. They're often the diabetics, they're often the very severe ones, and you'll get those ones who do well, it comes back, do well, it comes back. We don't know why that is, but the vast majority, 90–95%, usually one cortisone injection is all they get from me.
Okay. Now, is Kenacort better than Depomedrol, and if so, how much and why?
My preference is Kenacort, so I've always used Kenacort, and I've always used 40 milligrams of Kenacort in my injections, be it subacromial or intra-articular, and I make it up to 10 mils with xylocaine. And for me, I rationalize that these are big spaces that we're giving them into. I want that injection to disperse right through the bursa or right through the joint. I don't know that there has been any good evidence looking at the different preparations of cortisone to say one is better than the other in either intramuscular, intra-articular, or subacromial injections. Kenacort's just always been my preference. I've not, touch wood, had any real issues with it, so I've stuck with it.
Fair enough. Great. Okay. Oh, you partially answered this, and just to clarify for those of us who don't know much about hydrodilatation, do you mind just sort of expanding on what it is?
So the rationale, and it's a bit like a manipulation under anesthetic as well. So the rationale is that the fibroblastic or inflammatory type response within the capsule or the capsulitis causes thickening and contracture of the capsule, which tends to be global, which is why you tend to get that global range of motion loss. But it does tend to affect areas more specifically, like the rotator interval area, for example, tends to be most contracted. So with hydrodilatation, what they attempt to do is place a large bore needle into the shoulder, and with saline, they just progressively distend the capsule, partly thinking that if they distend the capsule before it becomes too contracted, that'll be a good way to restore the patient's range of motion. But also, the original descriptions of it were that they wanted to actually rupture the capsule as well, a bit like you try and do with the manipulation to break down any scar tissue or severe contractures that are forming. But again, that tends to be a little less controlled, and it depends entirely on what stage their capsulitis is at. If you've got someone who's really tight and really stiff, they're not going to get any fluid in there at all. So it really only works if you get people early, before they've got a lot of motion loss. But again, there's always the cortisone injection afterwards, which in my skeptical view probably is the most important part of that treatment.
Okay, all right. Let's have a look. What provocation test on examination do you find most useful in your diagnosis making?
So I have a very brief physical examination. I know through medical school and through orthopedic training we get taught to do the whole lot. So for me, I check range of motion, and I don't check all planes. I check more functional planes. So forward elevation, external rotation, internal rotation behind their back. That's about it. I never put the shoulder into abduction, because any shoulder pain will be much worse in abduction, because immediately you're just jamming the cuff up under the subacromial space. So then if they can't, I get them to actively do it, and then I try and take it further. So I always check for full passive range of motion. Then I do a brief assessment of strength, external rotation, thumbs down abduction, and do the belly press and lift off test for a strength of their cup. And by that stage, you're getting an idea. So if you bring their arms out and try and test strength of supraspinatus and they're quite sore, then you're thinking that this person's probably got some subacromial based pain. And then really all I do, if I'm thinking instability, I might do a couple of instability tests. If I'm thinking rotator cuff, I'll just really do an impingement test on them, either the Neer or Hawkins test, and just sort of assess where it's sore. But yeah, if someone's got a big tear, you'll notice some weakness, as long as they're not too sore with it. But if someone's having a lot of impingement, the provocative tests basically in abduction will always be sore.
Okay.
But the problem is they can be sore if someone's got an AC joint problem, they can be sore if someone's got a labral tear, they're definitely sore, and you often can't put them in that position if they've got a frozen shoulder. So yeah, we do some of these things. So all those special tests I don't tend to do because they're not that good in a painful shoulder.
Fair enough. Okay. Could you please advise on treatment for shoulder pain when identified doing a 9-to-5 job? So I guess those sort of referring to sort of repetitive injury type issues.
So I mean, my experience is a lot of those patients will be that middle-aged person. So often it becomes a postural issue with those things. So don't forget, as we've talked about from the anatomy part, it's not just the glenohumeral joint we're thinking of. So if you start to have poor postural control, your scapulars become protracted, then that narrows your subacromial space. Often people's workstations aren't set up properly, so they tend to be working away from their body. So they're then using their cuff in an overactive fashion. It fatigues. Then they start impinging. They get that secondary bursal inflammation. And so often it's a mechanical imbalance causing an impingement issue. So there usually isn't a structural issue associated with that. So that's where getting someone to do a proper assessment of their workstation so that they've got their keyboard height right, they're close to them rather than away from their body, and getting someone to see them and advise them about proper strength and postural control generally is all that's required. If they're really sore, yes, an injection, just to allow them to do the exercises and be comfortable.
Okay, great.
Good.
I think that pretty much wraps us up for tonight, actually.
Good.
Thank you so much for coming along.
That's
It's been
good.
fantastic. I've learned
Thank
a lot,
you.
and I'm sure our audience has also learned a lot. You can find more on our website, where you'll also find a copy of this talk later on. So thank you, everyone, for joining us, and good night.
Yes, thank you, and good night.